This is FX Medicine. I'm Andrew Whitfield Cook. We're here at the 2017 UIC, United in Compassion Conference, and I'm speaking with Justin Kander. Justin, tell me first about your qualifications and what your interest is.
My name is Justin Kander. I work for Aunt Zelda's in California. It's a cannabis collective that specializes in the production of cannabis extracts for treating cancer. I've been researching this for almost 10 years now, independently. I'm not a doctor. I didn't study science formally in college, but this has been a passion of mine for almost 10 years, and I've seen the science and the evidence grow tremendously since I got involved.
Now, you say treating cancer. My experience as a nurse is sort of allaying the symptoms of cancer when you're undergoing therapy. You're saying treating cancer.
Absolutely, and the reason it isn't as well known is because you need to be very intentional about the treatment. Smoking cannabis or using low doses of edibles, which is indeed great for symptoms, doesn't have an anti-cancer effect. You need to get up into higher doses to actually begin killing the cancer cells.
But it's still a big call, saying treat.
Yes.
That's okay, so where are we at there? Like, are you saying take the place of chemotherapeutic drugs and radiotherapy regimes?
Absolutely not. So there is differential responses to it. So most people and most cancers, when using a high dose of cannabis oils, do experience some kind of anti-cancer effect. But there are some people who don't respond, so you definitely do not want to forgo conventional therapy. Furthermore, there's substantial preclinical evidence that the cannabinoids work synergistically with the chemotherapy and radiation and help them work better to kill the cancer cells. So it's definitely the most conventional route, and the safest and most effective route is to combine it with the conventional therapies. So
no real issue with CYP interactions, with P-glycoprotein pump inhibition, so that you get a toxic reaction of a chemotherapeutic drug? You haven't seen that sort of issue?
It is indeed safest to separate the cannabinoids from the chemotherapy because of the cytochrome P450 interactions, right. It may raise the levels of the chemotherapy beyond the intended targets. So it is good to separate that. With radiation, thankfully, since it's not metabolized by those enzymes, you can use it concurrently. But with chemotherapy, you can still get the synergy by separating them.
Okay, so with a separation, you've got varying half-lives. Thankfully, much of them short because they're quite toxic drugs. But let's talk about, irinotecan or cisplatin or cyclophosphamide, for instance. Cyclophos, quite toxic to definitely the cancer and unfortunately the human host as well. What sort of time delay do you have to have before administering the cannabis?
In general, so we work with physicians who help integrate the cannabis into conventional protocols. In general, I believe they like to recommend to not use cannabis the day before, the day of, and the day after, and that tends to give enough time.
So a 2-day half-life.
Yeah, and that's in practice, that's been fine. There haven't been adverse reactions. I'm not familiar with every specific chemotherapy drug. There may indeed be some with longer half-lives where it's a problem, but we have not seen that effect in practice.
Now we're going to leave the legal issues to the other speakers and things like that because they are profuse. But with regards to having a cellular action versus a psychotropic action, and perhaps dare I say the word cultural issues with regards to whether they want that psychotropic effect. Do you find that the higher dosages definitely have a psychotropic effect, or do you find that when they're under the chemotherapy, radiotherapy regimen, that you indeed treating cancer, that you tend not to get a psychotropic effect with the higher dosage?
Well, there's absolutely a psychotropic effect. Even at the very low doses, it's very individualized.
Right.
So we like to give, most of our patients use 2 oils, one high in THC and one high in CBD. Since CBD is largely non-psychoactive, or at least doesn't have the psychoactivity of THC, they can start with a very low dose of THC and higher doses of CBD to get the advantage of the anti-cancer effects of the CBD while slowly increasing the THC and building their tolerance to it. Because if you do jump to a high dose, there can be very significant side effects like paranoia and anxiety, vomiting, But this is very well controlled by simply starting with a low dose and slowly increasing it.
And when you're talking about these products, are you talking about inhaled, imbibed, or oils, or what sort of products?
So people tend to use either infused oils like olive oil or MCT oil, or the full extract cannabis oil that comes in the syringes. It's the dark black oils.
Yeah.
So you can use either one to achieve the cancer level doses. But yeah, smoking it's very difficult. We don't recommend that for fighting the cancer because it's so hard to get a high dose, and of course, smoke has oxidants in it, and it's good to avoid if you can.
But there's the historical use of
Yes.
smoking. So it's sort of like, I guess it wasn't necessarily used for cancer culturally back in eons ago. But do you think that oils are necessarily the way to go? I guess where I'm heading here is cannabis can be grown, cannabis can be smoked by people in need, and I'm talking medical cannabis. Whereas an oil product, I'm gathering because of processing and things like that, the costs would surmount. So how affordable is this sort of regimen for most cancer patients?
It's tremendously expensive, actually. Even we try to keep our prices low, but because you need such high doses, it is expensive. With smoking, you can get symptomatic relief with very low doses, but for fighting cancer, the reality is it's expensive. Like $800 to $2,000 a month often, which is terrible. It needs, and this is it's purely because of Prohibition. If Prohibition wasn't here, the cost of the medicine would be much lower, and also insurance would be able to cover it. And the cost compared to pharmaceuticals is tremendously low.
But when you've got an insurance cost, the base cost is still there. It's just covered in another way through tax. So we've got to be mindful about ostensible costs and real costs. So are you saying that it's the Prohibition that's ramping up the real cost of the medicine?
Yes, it's ramping up both the real costs and preventing insurance from covering it. And so, insurance, most chemotherapies, they're tens of thousands, often hundreds of thousands of dollars a month. I'm not sure how cheap it could get without Prohibition, but that 800 to 2,000 number might come down to 200 to 500, which is so low compared to other drugs. So really, it would enable, one of the things I'm excited about is dramatically lowering healthcare costs so that people can pay lower taxes and the money can go to other things.
So with regards to this research, how's it going, and what sort of hurdles have you encountered with regards to Prohibition?
So the biggest hurdle is the actual clinical research. So there's a ton of research with cells and animals which clearly and unequivocally shows that THC and CBD kill most major forms of cancer cells in the cell and the animal studies.
Regardless of type of cancer, like sarcoma versus leukemias, solid tumors versus hematological?
It's almost unbelievable, but there are studies showing it kills glioma cells, melanoma, prostate cancer, pancreatic cancer, liver cancer. Most major cancers, there is the cellular evidence showing that it induces programmed cell death, and also they tend to test it on healthy cells as well and find that they don't kill the healthy cells. So it has a selective effect in only killing cancer cells.
So given that a cancer is not a cancer, it's a cancers, because it's a cell that's forgotten what it is, and so you get multiple receptors on these varying cancers, and even within one type of cancer, you can get one that's got one sort of, let's say VEGF, and another one that's more responsive to another receptor. You're saying that THC tends to be selective in these cancers. How then is it working? We're talking the endocannabinoid system, the CB1 or 2?
So THC is shown to induce apoptosis in cancer cells. A wide variety of them express either CB1, CB2, or both. And the interesting phenomenon is that many types of cancer have upregulated levels of these CB1 or CB2 receptors, which may be a protective mechanism to limit their spread, which happens in other conditions as well. After a traumatic brain injury, there'll be an increase in cannabinoid receptors, which is shown to have a neuroprotective effect. There may be a similar phenomenon with cancers where they express more cannabinoid receptors to be killed by our endocannabinoids.
So are you saying they upregulate these receptors basically to wave a flag to say, help me? Or are you saying that there's some other action there, that some other reason that these receptors are being...
That's what it appears to be. It appears, I mean, the research on that is very early, but it appears to be a protective mechanism, judging by the fact that the endocannabinoids, mainly anandamide, are shown to kill the cells by binding to those receptors, mainly CB1.
So a protective mechanism to the host, not to the tumour cell?
Yes.
Right, okay, because I was going, hang on, what are we protecting here? Okay, so next phase, what's happening? Where's the direction going?
We absolutely need clinical trials to further explore this. I personally believe that so for one, there has been now a placebo-controlled trial, the gold standard, which was conducted by GW Pharmaceuticals, and the results released in February of this year, 2017, that used 21 patients. Some got the THC and CBD along with chemotherapy, some got the placebo along with chemotherapy, and those with the cannabinoids lived 6 months longer than those who got the placebo, which can only be explained by the synergy against the cancer. And it was with a very low dose, a maximum of likely 62 milligrams per day, which is much lower than anecdotally people have been using, which has required hundreds of milligrams. So between the cell, animal, case report, and that clinical trial, I personally believe that the evidence that it can work against cancer is overwhelming, and what we should do is have trials with terminal cancer patients and begin studying them, because I personally believe at this point more placebo-controlled trials are cruel, because that placebo group is dying or sooner than they would or not being healed. So we still need research, we still need to optimize the therapy, but immediately cancer patients deserve access to this medicine under medical supervision, and we need further observational research, probably for decades, to determine both the extent and the limits of this medicine, and what's cultivars and cannabinoid terpene profiles are ideal for different cancers in different people.
One of the confounders, one last question for you. One last question is, just listening to Didi Mieri, and what happened with regards to autism, there seemed to be a particular phytochemical profile, a whole phytochemical profile of the many cannabinoids, not just THC, CBD, the terpenes, but a whole host of compounds. Then you have to try and match it up with the human host that will respond to that. That seems to be just so confusing as to water down any sort of effect. So what is the actual response that you're finding? Like, do you have to match a certain type of product to a certain type of patient, or do you find that generally they tend to work?
So the very, very thankful thing about cannabinoid medicine, and this is clear in the clinical trials that have used cannabis, is like clearly, they're all the clinical trials that exist, showing it works for chronic pain, multiple sclerosis, epilepsy, like the EpiDLX trials. They're not looking at what Didi showed, all those hundreds of cannabinoids and terpenes, but it's still working. And this shows that clearly there's more than one path to success. So we focus on THC and CBD levels, and we want cultivars that have terpenes that make it so the patient can get up to high doses without being uncomfortable, because certain terpenes and blends can make people uncomfortable and hard to get to high doses. So we like to see a wide spectrum of terpenes because they have anti-cancer effects as well. And most of our patients and many other caregivers are seeing that when you get to high doses of THC and CBD, you're seeing anti-cancer effects in most cancers in most people. That's just what's being reported. And we still need to optimize it.
I said one last question, but now I want to go one last question. So it's just tweaked something in my mind. That it's something that David Caldecott was mentioning about these terpenes, the alpha pineal, the beta-myrcene, things like that. These chemical compounds can be gotten from other plants. David whimsically said pinoclean for pineal, but they're also obtained from other plants. Has there been any research? Has anybody looked at maybe having THC and CBD and adding the terpenes from other sources, like, for instance, pinene from eucalyptus,
Or limonene from lemon oil.
Lemon oil, yeah, things like that. Is there any work done on that?
There is, to my knowledge, there's not. I think it's best to try to find cultivars that have the terpenes you want
In them.
without needing to add. There are many companies out there who are, for vape pens specifically, because most of the terpenes are lost in the processing, they do add it from other sources, but it doesn't seem to work as well.
That could be an adulteration issue.
Yes, it's in general, it's good to try to get the terpenes you want from cannabis in the whole plant. But we're still very early. It could be that using adding some lemon oil to it, will enhance the effect. We'll just have to see.
Yeah. Justin, thanks so much for joining us.
Thank you for having me. This is awesome. Thank you.
This is FX Medicine. I'm Andrew Whitfield Cook.